Hello everyone. In today's installment of Intern Crash Course, I'm talking about COVID-19. Consistent with the other videos in this series, this will focus on the presentation, diagnosis, and management of COVID-19, specifically in adults. This video will not cover epidemiology, policy, or politics. Only the absolute essentials of what frontline healthcare professionals need to know about this awful disease. I also won't be discussing personal protective equipment in any detail because by now every institution has developed its own PPE policies based on local needs and local resources. This is actually an updated version of this video. The original was posted in April. The primary changes are in the treatment and PPE sections. I know this is likely obvious, but keep in mind that there is an unprecedented volume of research being performed and published about COVID at an unprecedented rate. Therefore, while I have done my best to make the information presented in this video as accurate as possible, some of it will become outdated over the coming months. I'll start by clarifying two relevant terms. SARS-CoV-2 is the name of the virus. This is to distinguish it from SARS-CoV-1, the similar coronavirus that was responsible for the SARS epidemic of 2003. COVID-19 is the disease caused by the SARS-CoV-2 virus. COVID-19 stands for Coronavirus Disease 2019. This is roughly analogous to HIV the virus and AIDS the disease. Now let's discuss the clinical presentation of COVID-19. Dry cough, fever, and myalgia are the most commonly reported symptoms. While almost all symptomatic patients will develop a fever at some point during their illness, a significant number of them do not have fever at the time of initial presentation. In other words, the absence of fever does not rule out COVID. In approximately descending order of frequency, other well-described symptoms include headache, dyspnea, sore throat, abnormalities of taste and smell, diarrhea, and nausea and vomiting. Among all patients who develop COVID-19, approximately 80% have so-called mild disease. Mild is sort of a misnomer because some of these individuals will feel really terrible. However, what mild actually means is that hospitalization is not required. 15% of patients will be classified as severe on account of requiring hospitalization, usually for dyspnea and hypoxemia brought on by viral pneumonia. And 5% of patients will be classified as critical, meaning ICU admission, usually for ARDS and/or multi-organ failure. As the pandemic has evolved in the US, anecdotally, these numbers have shifted a bit as more mild cases are being recognized, resulting in a proportional decrease in the percentage of severe and critical cases, but updated reliable specific numbers are not available. An uncertain percentage, but probably a minority of patients infected with the SARS-CoV-2 virus remain asymptomatic. Asymptomatic individuals are nevertheless contagious and can spread the virus to others who may then become ill. Here's the time course of symptoms for a typical patient ill enough to require hospitalization. It starts with an asymptomatic incubation period ranging from about 2 to 14 days, the median length of 4 to 5 days. At least some patients will be contagious during the tail end of this asymptomatic period. The initial symptoms to develop are most commonly fever and cough, which can last the duration of the illness, though in some patients, fevers cease before full recovery. Then, in the 20% of patients eventually requiring hospitalization, dyspnea develops after about a week of symptoms, which then coincides with the typical timing of their admission. In the 5% of overall patients, meaning in the 25% of hospitalized patients, ARDS and multi-organ failure typically follows the onset of dyspnea by a few days. Among hospitalized patients, either recovery or death usually occurs between 2 and 3 weeks after initial symptom onset, though in some cases, recovery to the point of discharge can take substantially longer than this. For patients with mild illness, recovery typically is seen more quickly. While many COVID-19 patients who present with dyspnea have hypoxemia and/or pulmonary crackles, there are no physical exam findings that are specific enough to be diagnostically helpful. While there are no pathognomonic lab findings in COVID-19, it is commonly associated with a distinctive combination of abnormalities, including lymphopenia, elevated LDH, elevated ferritin, and elevated CRP. When it comes to radiographic findings, while some are now being considered typical of COVID, they are nevertheless nonspecific. Radiography cannot differentiate COVID-19 from other forms of pneumonia. But what are some common findings? On chest X-ray, approximately 1/3 of them are normal at the time of initial presentation. A normal chest X-ray does not rule out COVID. However, the majority of patients show patchy infiltrates and/or consolidations, most commonly in a bilateral, peripheral, and basilar distribution. These findings and this pattern becomes most apparent at least 1 week after the onset of symptoms. Pleural effusions are uncommon. On chest CT, most patients have bilateral subpleural ground glass opacities, and as with plain chest films, consolidations can be seen, particularly late in the illness. There are some common acute complications of COVID-19. As already mentioned, one is hypoxemic respiratory failure, secondary to ARDS. This appears to be the most common mechanism of death in these patients, and which can be accompanied by bacterial superinfection requiring antibiotics. Some critically ill patients also develop a multi-system inflammatory syndrome, characterized by persistent high fevers, elevated pro-inflammatory cytokines, cytopenias, and multi-organ failure. Another complication in critically ill patients is an increased risk of thromboembolism and microvascular thrombosis, including pulmonary emboli and strokes. Last of the well-described complications is cardiomyopathy, though it is not yet known what the relative contributions are from viral myocarditis, stress cardiomyopathy, also known as Takotsubo cardiomyopathy, ischemic injury from microvascular damage, or from cytokine storm. Let's move on to diagnosis. A diagnosis of COVID is based upon symptoms, the current disease prevalence in the community, and a reverse transcription PCR test for the virus, usually performed on nasopharyngeal swabs. In settings where the Rt Pcr test is not available, a patient with consistent symptoms coming from a community with a reasonably high prevalence of the disease and in whom other common diagnoses have been ruled out can be considered to have presumed COVID and should be treated accordingly. The major limitations of the Rt Pcr test include the fact that there is currently no gold standard for the diagnosis, so we don't know the true sensitivity and specificity of the test. Whatever the sensitivity of the test happens to be, it will be dependent upon the phase and severity of illness, as well as collection technique. Proper collection requires inserting the swab deeper into the nasopharynx than most people realize, and it is uncomfortable if done correctly. Also, different labs have developed slightly different tests, and it is unknown how the sensitivities compare between them. A general recommendation is if the suspicion that a patient has COVID-19 is high, but the initial Rt Pcr test is negative, to keep the patient isolated either in the hospital or at home, and then have them retested in several days if the uncertainty still remains. Serologic tests are newer and can identify anti-SARS-CoV-2 antibodies in patients who are either late in their course of illness or who have already recovered. But serologic tests have a limited role in diagnosing acute infections. Stanford, where I practice, has begun to use a test called a negative strand or minus strand PCR test that is intended to identify actively replicating virus in an effort to determine current infectivity. However, at this time, such a test is not widely available and its clinical utility is uncertain. Treatment of COVID-19 is predominantly supportive and is focused mostly on improving oxygenation, as that is the primary problem in the overwhelming majority of severe and critical cases. So, how do we do that? For patients with severe but not yet critical disease, that is, who are pre-intubation, start with regular old low-flow nasal cannula. If that is insufficient, upgrade to high-flow, keeping in mind that high-flow oxygen is generally considered to be an aerosol-generating intervention requiring a negative pressure room and additional PPE for providers if available. An intervention that has gotten very little attention in pulmonary diseases prior to COVID, but which has been found, at least anecdotally, to be very helpful, is awake prone positioning, aiming for 12 to 16 hours per day. Some patients will find this uncomfortable, so adherence can be a challenge. And consider the selective use of non-invasive positive pressure ventilation. Decisions about whether to employ CPAP or BiPAP for a given patient need to balance four things: the probable relatively low benefit of NIPPV in COVID-19, preservation of invasive mechanical ventilators, the relatively low rates of successful extubation in these patients, and the increased risk to staff from NIPPV on account of aerosolization of secretions. The debate about NIPPV use in COVID is ongoing and unlikely to be settled anytime soon. Speaking of areas of debate, let's talk about intubation. Patients with COVID can experience extremely rapid respiratory deterioration after a period of apparent stability. This has led many critical care experts to advocate for so-called early intubation, for example, intubating patients at thresholds of hypoxemia that are not as severe as usually employed. However, some others have pushed back on this practice due to the same arguments favoring the use of non-invasive ventilation, that early intubation may contribute to ventilator shortages and could increase mortality by unnecessarily subjecting patients to all the risks associated with mechanical ventilation, such as barotrauma and ventilator-associated bacterial pneumonia. If the decision is made to intubate, keep in mind that extra time needs to be allotted for the airway team to gather, prepare, and don personal protective equipment. And the intubation itself should be performed by the most experienced person present. These are not the patients to give the prelim intern first crack at the airway. For patients that do end up intubated, low tidal volume ventilation, the conventional approach to ARDS, is recommended. There are a few other approaches to modes and settings that have been tried and may be successful. If whatever mode and setting is insufficient, prone positioning should be used, and as a last resort for refractory hypoxemia, veno-venous ECMO can be considered if it's available. Now, what about some COVID-specific therapies? The following is 100% consistent with current guidelines from the Infectious Diseases Society of America. In order of decreasing effectiveness, based on our current knowledge, the most helpful medication is dexamethasone. This is indicated for anyone requiring supplemental oxygen. The standard dose is 6 milligrams, either IV or PO, daily for 10 days or until the patient is discharged, whichever comes first. Dexamethasone is cheap and very widely available, but if for some reason it isn't available, prednisone 40 milligrams daily can be used as a substitute. Next is remdesivir. Remdesivir is an antiviral indicated for anyone with an O2 sat of 94% or less. This standard dose is 200 milligrams IV on day 1, followed by 100 milligrams daily for 4 additional days. Unlike dexamethasone, remdesivir is very expensive, not widely available, and has no specific substitute. And we also have convalescent plasma, which is antibody-rich plasma donated from COVID survivors. Here in the US, convalescent plasma was granted an emergency use authorization by the FDA in August, but this was based on limited data. The level of evidence needed for an EUA is less than needed for a conventional approval, and it's not even clear if convalescent plasma met the usual standard of evidence for an EUA. It should not be considered standard of care at this time, and it's preferable to only use it within the context of a clinical trial. There are a few other considerations with treatment. One is anticoagulation. If a patient has another indication for anticoagulation, such as atrial fibrillation, a mechanical valve, or new thromboembolism, generally follow anticoagulation guidelines for that indication. If the patient has no pre-existing indication and is critically ill, prophylactic full or half-dose therapeutic anticoagulation might be appropriate. Although we know these patients are at a high risk of developing thrombosis in various locations, we don't actually know yet what the best approach is to anticoagulation. To help answer this question, the enrollment of the patient in a clinical trial of anticoagulation is preferred if available, but it's not necessary. And if the patient has no pre-existing indication and has severe but not critical disease, conventional prophylactic anticoagulation is most appropriate, such as low molecular weight heparin. There has been a lot of speculation about the role of ACE inhibitors and ARBs in COVID. Some researchers believe that chronic ACE and ARB use may be associated with worse outcomes in COVID, while others have proposed it as a COVID treatment. For now, until we know more, it is recommended to initiate, continue, or discontinue these medications as otherwise indicated without COVID-specific considerations. And as with other interventions of unknown benefit, consider enrolling the patient in a clinical trial. While there are many other COVID therapies that have been proposed with varying degrees of plausibility, I do not recommend the use of anything else outside of a clinical trial. All of the other treatments that you may have heard about are currently of unproven safety and efficacy, or in some cases have been sufficiently proven to be ineffective. How do we determine prognosis in COVID-19? The true mortality rate in COVID-19 is uncertain and an area of significant controversy. Mortality varies dramatically by age and has declined since the start of the pandemic across all age groups. The current case fatality rate in the US is in the neighborhood of about 2%. That means of all individuals who are currently being diagnosed with COVID, about 2% of them will die because of the illness. However, that number ranges from virtually 0% among healthy school-aged children to double digits in elderly individuals with significant comorbidities. The infection fatality rate, which includes undiagnosed cases and asymptomatic infections by SARS-CoV-2, is much, much lower. There have been many identified risk factors for COVID-related death. Demographic risk factors include advanced age, as already implied, particularly of about 60 to 70 years, and male sex. Comorbid conditions that are risk factors for death include all of the usual suspects: cardiovascular disease, chronic lung disease, diabetes, hypertension, cancer, chronic kidney disease, obesity, and any form of immunocompromise. Among patients who are admitted to the hospital with COVID, between survivors and non-survivors, there is no significant difference in symptoms or time course of illness prior to initial presentation, but lab tests which appear to be risk factors for death include lymphopenia, an elevated D-dimer with a degree of elevation related to the risk, and elevations of troponin, LDH, AST and ALT, creatinine, ferritin, and C-reactive protein. An elevated SOFA score is also predictive of mortality. When it comes to PPE, guidelines and recommendations differ across countries, states, healthcare systems, and individual hospitals. I so wish this was not the case, but some of these differences are being driven by a lack of optimal PPE, even 6 months into the pandemic. But it's usually unclear to frontline healthcare professionals to what extent the availability issue is driving these recommendations. And with evolving data on PPE effectiveness and with local changes in PPE availability, you should expect guidelines, recs, and protocols to change. In general, you should follow your hospital's local protocols, but if you feel those protocols are unsafe, you should speak up to the greatest extent that you feel you can. The most important thing to remember about PPE is that its proper usage and removal is at least as important as the specific equipment available at your institution. That's it for this video on the presentation, diagnosis, and management of COVID-19. As discussed at the beginning, knowledge about this disease is being updated at an incredibly fast rate, so please keep that in mind. And stay safe out there.